The man who died on my table had just passed his physical. Perfect cholesterol. Normal blood pressure. Fit for his age. That's what his chart said. But when we opened his artery, it was already too late. He was 67, played golf twice a week, walked every morning, never missed his annual checkup. If you saw him in the waiting room, you would have thought, that's someone doing everything right. And yet, 20 minutes after arriving in the ER, his heart stopped. Now here's the part that should concern you. Because cases like his, they are not rare. In fact, they are becoming more common. I'm Dr. Olivia Kesson, cardiovascular surgeon for over 20 years. And I need to tell you something most people your age have never been told clearly. Heart attacks are almost never random. They feel sudden. They look sudden. But the damage has usually been building silently for 10, 20, sometimes 30 years. And here's the real problem. The tests most people rely on often miss it completely. Not because your doctor doesn't care, not because you did something wrong, but because the standard checkups you've been trusting were never designed to catch the real danger early enough. So today, I'm going to show you what's actually happening inside your arteries before a heart attack ever strikes. Because once you understand this, you'll never look at normal test results the same way again. Let's start with something simple, but almost nobody fully understands what a heart attack actually is. Most people think it's a blockage that slowly builds up until blood can't get through. That's what it looks like. That's what it sounds like. But that's not what usually kills people. What actually happens is far more sudden and far more dangerous. Your heart is a muscle, and like any muscle, it needs a constant supply of oxygen. That oxygen comes from your coronary arteries, small vessels wrapped around your heart. Over time, fatty deposits begin forming inside the artery wall. This is called plaque. Now here's the part most people don't realize. That plaque can sit there for years. No symptoms, no warning signs, no pain. You can walk every day, eat pretty healthy, feel completely fine, and still have plaque quietly growing inside your arteries. But then, one day, something changes. That plaque becomes unstable. The outer layer gets thin, fragile, like a weak spot on a tire. And when it ruptures, your body reacts instantly. It thinks you're bleeding. So it forms a clot. But that clot can grow so fast, it completely blocks the artery. And the moment that happens, blood flow stops, oxygen stops, and within minutes, heart muscle cells start to die. That is a heart attack. And here's the detail that changes everything. The plaque that ruptures is often not the biggest one. It's not the one your stress test would catch, not the one causing obvious blockage. It's usually a smaller, softer, more dangerous plaque that nobody even knew was there, which is exactly why someone can be told their heart is fine and still have a heart attack days later. Now think about that for a second, because this is where most people get it wrong, especially after 60. They believe risk looks a certain way: overweight, out of shape, clearly unhealthy. But in real life, that's not what I see in the operating room. I see people who look completely normal, and that's where the real danger begins. Before we go deeper, I'm going to show you the exact types of healthy-looking patients who end up with heart attacks and why standard tests miss them. The most dangerous heart patient is often not the one who looks sick. It's the one nobody worries about. The man who walks in without a cane, still drives, still plays tennis, still says things like, "I'm in pretty good shape for my age." And maybe he is, at least on the outside. But heart disease does not care what you look like in clothes. It does not care whether people call you slim. And it definitely does not care whether your last routine visit ended with "everything looks okay." Because one of the most important ideas in cardiovascular medicine is this: you can look healthy and still be building dangerous disease on the inside. There's actually a term for one version of this: TOFI, thin on the outside, fat on the inside. It's a medical reality. These are people who may not look overweight at all, but are carrying a dangerous amount of visceral fat. That's the fat stored deep inside the abdomen, wrapped around organs, pushing the body toward inflammation, insulin resistance, high blood pressure, and artery damage. This is not the fat you can pinch with your fingers. This is the fat you often don't see until the damage is already happening. That is why body weight alone can be misleading. A person can have a normal number on the scale and still have a metabolic profile that is quietly pushing them toward heart disease. And after 60, this becomes even more important because body composition changes. Muscle often declines. Fat distribution changes. The waistline grows even if total weight doesn't change very much. So when someone says, "But I'm not overweight," that does not automatically mean their heart risk is low. Now let's talk about another group I see all the time: the person who looks fit, but eats terribly. You probably know someone like this. Maybe it's even you. They stay active. They don't seem heavy. Maybe they've been naturally thin their entire life, so they assume their diet can't be doing much harm. But day after day, ultra-processed foods, refined carbohydrates, sugary snacks, sweet drinks, late-night eating can slowly destroy metabolic health without changing the mirror very much. And that is exactly what makes this so deceptive, because the outside stays reassuring, while the inside becomes more unstable. Blood sugar begins spiking more often. Insulin stays elevated longer. Triglycerides rise. Inflammation increases. Fat starts collecting where it causes the most harm, and the artery wall begins changing quietly. This is one reason some people are so shocked by a heart attack. They weren't ignoring their health. They were just measuring the wrong things. Now there's another group that surprises people even more: the lifelong exerciser, the walker, the cyclist, the golfer, the man who has done cardio for 30 years, the woman who has never missed her fitness class. Exercise is absolutely protective. Let me be clear, it matters enormously. Regular movement lowers risk, improves blood pressure, improves insulin sensitivity, helps control weight, improves circulation. It is one of the best things you can do for your heart. But exercise is not magic. It cannot fully erase decades of underlying plaque formation. It cannot change certain genetic risks, and it cannot guarantee that a vulnerable plaque isn't already there. This is why some very active people still end up with heart disease. Not because exercise failed, but because exercise is only one part of the story. A person can be active and still have a strong family history, elevated lipoprotein A, high blood pressure at home, insulin resistance, chronic inflammation, a calcium score they would never expect, and unless someone goes looking, they may never know. That is one of the hardest truths for people over 60 to hear, because many have done a lot of things right, and they should get credit for that. But heart disease doesn't operate on effort alone. It operates on biology. That's why this video matters, because what you feel and what is actually happening inside your arteries are not always the same thing. Cardiovascular disease is invisible until suddenly it isn't. You don't feel plaque forming. You don't feel insulin rising. You don't feel inflammation injuring the lining of your blood vessels. You don't feel a vulnerable plaque getting thinner and more unstable. By the time you feel the crushing chest pressure, the shortness of breath, the nausea, the sweating, the weakness, you are already in the emergency phase. And that is exactly why prevention has to begin long before symptoms appear. Now, here is the single most important shift I want you to make, especially if you're over 60. A heart attack is almost never a bolt from the blue. It is usually the final event in a process that has been building for years, often decades. It feels sudden, but biologically, it almost never is, and we know this because the evidence is startling. Researchers have looked at the arteries of young people, teenagers, people in their 20s, people in their 30s, who died from accidents, not heart disease. And what they found was deeply unsettling. Early artery changes, the very first signs of atherosclerosis, were already there. Think about that. Before retirement, before Medicare, before senior discounts, before most people even start thinking seriously about their heart. The process had already begun, which means something very important. The heart attack at 68 did not begin at 68. The heart attack at 72 did not begin at 72. It may have started 20, 30, even 40 years earlier, silently. And once you understand that, everything changes. Because now the question is no longer, why did this happen so suddenly? The real question becomes, what has been quietly driving this all these years? And that is where the story gets even more important, because there are a few major forces that keep this disease moving forward in the background, even in people who think they're doing fine. And the first one? Most people have heard the word, but almost nobody really understands how it works. It's called atherosclerosis. If a heart attack is not sudden, then something has been pushing it forward for years. Not one thing, not one bad meal, not one stressful week, but a set of quiet forces working in the background every single day. And the first one is the foundation of almost all heart disease: atherosclerosis. Now I want you to picture this simply. Think of your arteries like flexible pipes, smooth on the inside, designed for blood to flow easily. But over time, under the wrong conditions, those inner walls start to change. Fatty particles begin slipping into the wall, not sitting on top, but embedding inside it. And your body reacts. It sends immune cells. It tries to clean it up. But instead of fixing the problem, it creates a slow, growing buildup. That buildup is plaque. Now here's what most people don't realize. Your artery does something clever. As plaque grows, the artery wall actually expands outward. So the inside space where blood flows can still look normal for a long time, which means you can have significant disease without any symptoms, and even without abnormal routine test results. No chest pain, no warning sign, no obvious blockage, just silent progression. And that's why standard testing often misses it, because it's not measuring what's happening inside the wall. Now here's the critical part. This process does not happen randomly. It follows patterns, predictable ones. A massive global study, over 50 countries, tens of thousands of people, found that most heart attacks can be traced back to a small group of modifiable factors, not hundreds, not mysteries, just a handful of drivers repeating over and over again, which means this disease is not just treatable, it's largely predictable, and that means it's often preventable, but only if you understand what's actually driving it. So let's move to the second force, and this one is severely underdiagnosed: insulin resistance. Now stay with me here. because this is where many healthy people get into trouble. Insulin is the hormone that controls your blood sugar. When everything works properly, you eat, your blood sugar rises, your body releases insulin, and your cells respond. Sugar moves out of your blood into your cells, and everything stays balanced. But over time, your cells can become less responsive. Now your body has to release more insulin to do the same job. And here's the dangerous part. Your blood sugar can still look normal. Your A1C can be fine. Your doctor says everything looks good. But your insulin is already elevated, and that matters a lot. Because high insulin does not just affect sugar. It affects your arteries. It increases inflammation. It promotes fat storage, especially visceral fat. It raises triglycerides. It damages the inner lining of blood vessels. And over time, it accelerates plaque formation. There was a long-term study that followed men over years and found something very concerning. Those with the highest insulin levels had up to 5 times the risk of developing heart disease, even when their cholesterol was completely normal. 5 times. Let that sink in. Normal cholesterol, normal blood sugar, and still significantly higher risk, because the problem was already developing beneath the surface. And here's why this is so important, especially after 60. Because insulin resistance becomes more common with age, less muscle mass, more abdominal fat, less physical activity, more years of dietary patterns catching up. All of this pushes the body slowly toward insulin resistance. And unless someone is specifically testing for it, it often goes unnoticed. Now let's move to the third driver, chronic inflammation. This one is quieter, but just as dangerous. Your immune system is designed to protect you. Short bursts of inflammation are helpful. They heal injury, fight infection. But when inflammation stays elevated, day after day, month after month, year after year, it becomes destructive. It starts damaging your blood vessels, and more importantly, it changes the nature of plaque. It turns stable plaque into unstable plaque, the kind that is more likely to rupture, the kind that leads to sudden blockage, the kind that causes heart attacks. There was a major clinical trial that looked directly at this. They didn't change cholesterol. They didn't focus on diet. They simply reduced inflammation. And what happened? Heart attacks dropped. Cardiovascular deaths dropped, which tells us something critical. Inflammation is not just a side effect. It is a driver of heart disease. And like insulin resistance, you often don't feel it. No pain, no obvious symptoms, just gradual damage to the artery wall. Now let's talk about the fourth driver. And this one is personal for many people watching: genetics. Because sometimes the risk you carry is not about lifestyle. It's something you were born with. There is a particle in your blood that most people have never heard of: lipoprotein A. It carries cholesterol, but behaves very differently from standard LDL. And here's the key. It is genetically determined. You inherit it from your parents. Lifestyle changes barely affect it. And if it's elevated, your risk of heart disease can double or even triple. Now here's the problem. Most people have never been tested for it, even though a significant portion of the population has elevated levels. So someone can live their entire life thinking, my cholesterol is fine, while this hidden risk factor has been present since birth. And unless it's measured, it stays invisible. Now I want to pause here for a moment, because all 4 of these drivers, atherosclerosis, insulin resistance, chronic inflammation, genetic risk, they all share one critical feature. You usually don't feel them. They don't cause pain. They don't send warnings. They don't interrupt your day. They just keep progressing, quietly, until one day, they don't stay quiet anymore. And that moment is what we call a heart attack. Let me ask you something. When your doctor says your numbers look good, what does that actually mean? Most people assume it means they're safe. But in cardiovascular medicine, that assumption can be dangerously misleading because the standard tests most people over 60 rely on are not designed to catch early disease. They are designed to catch late problems. And by the time those show up, the process has often been building for decades. Let me show you what I mean. When you get a routine blood test, your doctor usually checks total cholesterol, LDL, bad cholesterol, HDL, good cholesterol, triglycerides. Those numbers matter. They are useful, but they don't tell the full story. Because cholesterol tests measure how much cholesterol is being carried in your blood, not how many particles are actually damaging your arteries. And that distinction changes everything. Think of it like this. You could have a small number of trucks carrying a lot of cargo, or a large number of trucks each carrying a little. Your standard test only tells you how much cargo there is, but the damage to your artery wall comes from the number of particles crashing into it. And that's why someone can have normal cholesterol and still be at risk, because the particle count may still be high. This is where a more advanced marker comes in. ApoB. ApoB is a protein that sits on every single atherogenic particle, the ones capable of entering your artery wall. One particle equals one ApoB. So instead of estimating risk, you're actually counting the number of harmful particles. And studies show this is often a better predictor of heart disease than LDL alone. But here's the issue. Most people have never had it tested. It's not routinely ordered in standard checkups, which means a major piece of your risk profile may never be seen. Now let's go deeper, because there's another test that can completely change how you understand your risk. We mentioned it earlier, but this is where it really matters. Lipoprotein A. This is not just another cholesterol number. It's a genetic risk factor. You inherit it. You don't feel it. And most routine panels don't include it. Yet, if it's elevated, your risk can be significantly higher for your entire life, and many people only discover it after a cardiac event. Now let's talk about something even more hidden. Insulin. Not blood sugar. Not A1C. Insulin itself. Because remember, you can have normal blood sugar while your body is working overtime to keep it that way. That overwork is insulin resistance, and unless insulin is measured directly, it often goes undetected, which means one of the most powerful drivers of heart disease isn't even being checked. Now, here's a simple one almost nobody talks about, but it's incredibly useful. Your triglyceride to HDL ratio. This uses numbers you probably already have. Take your triglycerides and divide them by your HDL. That ratio gives insight into metabolic health and insulin resistance. A lower number is better. Higher numbers often signal underlying problems, and yet, most patients are never told what their ratio means. Now let's move to inflammation. We talked earlier about how chronic inflammation damages arteries, but how do you measure it? With something called high-sensitivity CRP. This is a blood test that detects low levels of inflammation in your body. Not infection, not acute illness, but the kind that slowly damages your blood vessels over time. Higher levels are associated with higher cardiovascular risk, but again, it's not always included in routine screening. So now you can see the pattern. The most important drivers of heart disease are often not part of standard testing, which means people are being told they're fine based on incomplete information. Now, I want to show you one of the most powerful tools we have, because this one doesn't estimate risk. It shows it. It's called a coronary artery calcium scan. This is a specialized CT scan that looks directly at your coronary arteries. And what it detects is calcium deposits inside plaque. In other words, it shows whether plaque is already present, not predicted, not assumed. Actually there. If your score is 0, that's reassuring. But if it's elevated, it means disease has already developed, even if your cholesterol is normal. Your blood pressure looks okay. You feel completely fine. This test has been shown in large studies to be one of the strongest predictors of future heart attack risk because it reflects what is already happening inside your arteries. And yet, many people don't even know it exists. Now step back and look at the bigger picture. Standard tests give you a snapshot of surface-level numbers. Advanced markers show you the underlying process, and if you only rely on the basics, you may miss the warning signs completely. Which brings us to the most important question. If these markers matter, how do you actually get them tested? Because walking into a doctor's office and asking for all of this isn't always straightforward. At this point, you might be thinking, okay, this all makes sense, but how do I actually do something with it? Because knowing the risk is one thing. Getting the right care is something else entirely, especially after 60, when most people are used to short appointments, quick labs, and being told, you're doing fine. So let's make this simple. If you want a clearer picture of your heart risk, you don't need to ask for everything at once. You need to ask the right way, because how you frame the conversation changes everything. Step 1. Start with your reason. Doctors respond to context, not just requests. So instead of saying, I saw this on YouTube and want these tests, say this: my father had a heart attack in his early 60s. Or, I've been told my numbers are normal, but I want to understand my risk more clearly. That one sentence does something important. It signals, you are not anxious, you are informed. And it shifts the conversation from routine screening to risk assessment. Step 2. Be specific, but focused. Don't ask for more tests. That often leads nowhere. Ask for specific markers. Start with ApoB lipoprotein. These two alone can dramatically improve how your risk is understood. Then, if appropriate, ask about fasting insulin, high sensitivity CRP. You don't need a long list. You need the tests that reveal what standard panels miss. Step 3. Understand availability. Now here's the reality. Depending on where you live, some of these tests may not be routinely offered. That doesn't mean they're not important. It just means you may need to ask directly or consider having them done privately. And that's okay, because the goal here is not convenience, it's clarity. Step 4. Know your numbers at home. This is one of the simplest and most powerful steps, and almost nobody does it properly. Measure your blood pressure at home. Not once, not randomly, but consistently over several days, because a single reading in a clinic can be misleading. Stress, rushing, anxiety, all of it can distort the number, but your home readings, they tell the truth. And for many people over 60, this is where hidden risk first shows up. Step 5. If you're told you're fine, pause and ask one simple question. I understand my cholesterol looks okay, but is there anything else that could give a fuller picture of my cardiovascular risk? That question changes the dynamic. It shows respect, but also awareness, and a good doctor will recognize exactly why you're asking, because medicine has moved forward, but routine screening has not fully caught up. Step 6. Consider imaging when appropriate. If you have family history, unclear risk, or simply want more certainty. Ask about a coronary artery calcium scan. This is not for everyone, but for the right person, it can be life-changing because it answers one critical question. Is there already plaque in my arteries? Not estimated, not predicted, actually present. And once you know that, your decisions change, your urgency changes, your priorities change. Now let's bring this together. You don't need to become a medical expert. You don't need to memorize every test, but you do need to understand this. If you only rely on routine checkups, you may only see the surface. And heart disease does not start on the surface. It starts deeper, earlier, quieter. And by the time it becomes obvious, you're already in the danger zone. But here's the good news. If you catch it early, you can change the entire trajectory. Not just delay a heart attack, but potentially prevent it entirely. And that brings us to the final piece. Because once you understand your risk, the next question becomes, what actually reduces it? So now you know the truth. Heart attacks are not random. They don't come out of nowhere. They are the end result of processes that have been building quietly for years. And that means something powerful. You still have control. Not over everything, not over genetics, not over the past, but over what happens next. Because once you understand how heart disease actually develops, the strategy to slow it down, even reverse parts of it, becomes much clearer. And it's not complicated, but it does require consistency. 1. Reduce visceral fat. This is the priority. If there is one target that changes everything, it's this. Not just weight, not just the number on the scale. Visceral fat. The fat around your organs. The fat that drives inflammation, insulin resistance, high blood pressure, artery damage. After 60, this becomes the central battlefield, because even small reductions in waist size can significantly improve metabolic health. Not dramatically, not overnight, but steadily over months. 2. Move your body the right way. Exercise is not optional, but it's also not what most people think. You don't need extremes. You don't need exhaustion. You need consistency. A combination of regular walking, light to moderate cardio, basic strength training. Because after 60, muscle matters. Muscle improves insulin sensitivity, supports metabolism, protects against decline. Even simple resistance work, done regularly, can change your trajectory. 3. Control your blood pressure. Don't guess it. This is one of the most overlooked risks because high blood pressure doesn't hurt, it doesn't warn you. But day after day, it damages the inner lining of your arteries. And once that lining is damaged, plaque forms more easily. So don't rely on occasional clinic readings. Measure at home. Track it. Understand your numbers. Because small elevations, over time, create major damage. 4. Fix the diet that's quietly driving the problem. Not by following trends, not by extreme restriction, but by removing what's causing damage. The biggest issue today is not fat. It's ultra-processed food. Foods engineered to be easy to eat, easy to overeat, and easy to repeat. These foods drive insulin resistance, increase inflammation, disrupt appetite signals, replace protective nutrients, and over years, they reshape your metabolism. So the shift is simple. More whole foods, vegetables, legumes, nuts, seeds, healthy fats, less packaged snacks, refined sugars, highly processed meals, not perfection, but direction. 5. Take sleep seriously. This is not optional. Sleep is not just rest, it is metabolic repair. Poor sleep raises blood pressure, worsens insulin resistance, increases inflammation, disrupts hormones, and over time, it accelerates heart disease. After 60, sleep quality often declines, which means you have to protect it intentionally. 6. Manage stress like it's a medical issue because it is. Chronic stress is not just emotional, it's biological. It raises cortisol, raises blood pressure, raises blood sugar, promotes visceral fat, and it increases the tendency of blood to clot, all of which pushes you closer to a cardiovascular event. So stress management is not a luxury, it's a preventive strategy. 7. Don't ignore the obvious one, smoking. Even now, it remains one of the strongest predictors of preventable death, and the damage is cumulative. If you smoke, stopping is one of the most powerful decisions you can make, at any age. Now let's bring everything together. Most people think the goal is this: avoid a heart attack in the next few years. But that's not the real goal. The real goal is to stop the process before it reaches that point. Because once plaque becomes unstable, you're reacting. But before that, you have time. And that window is often much larger than people realize. Here is the single message I want you to remember. Do not assume that normal tests mean a healthy heart, because what matters most is often not being measured. Ask better questions, look deeper, understand your risk, and then act on it. Not perfectly, not all at once, but consistently. Because heart disease does not change overnight, and neither does prevention. It compounds, just like the disease does, but in the opposite direction, toward strength, toward stability, toward time. And if you've stayed with me to this point, then you're already doing the most important part. You're paying attention. And that alone puts you ahead of most people. If this helped you, share it with someone your age, because the person who looks the healthiest may be the one who needs this most. I'm Dr. Olivia Kesson. Stay aware, stay consistent, and I'll see you in the next video.